Okay, you are most welcome for this EMS Eco session for today. And I would like to bring you on board for our discussion today.
Telling you, before we came for this.
We are in for the session. I would like to welcome members who are online. Welcome for this EMS Eco session for today. We are going to discuss altered mental status and seizures as our topic today. I would like to welcome the panel of experts. What's it? Come on, unmute this possible. I don't know what's here. Good afternoon, members out there. You're most welcome for this EMS Eco session for today. My name is Ronald Nkonge. I'm a senior clinical officer working with the China-Uganda Friendship Hospital. I'm going to be your moderator today. I'd like to welcome the expert team. Good afternoon, experts. We have kicked the session running and would like you members out there to be handling the questions, the pre-tests, such that we are able to see the background on which we are going to see this session. At this time, I would like to introduce the experts. We are going to start with the ladies. Ladies first, please. You're going to introduce yourself to the class. You're welcome.
Okay. Good afternoon, everybody. My name is Dr. Doreen Okong Alalate. I'm an emergency physician. I'm currently working at Kampala Capital City Authority, where my roles are to supervise, to advise and support emergency medical services for the Kampala metropolitan area. I'm glad to.
Dr. Doreen, you're most welcome. Please, Dr. you're going to introduce yourself to the participants.
Good afternoon, participants, health workers. I greet all of you. I am Dr. Richard Indro. I'm a pediatrician. Long
It's just wow.
Yeah. Minutes.
Okay, we are sorry for the hitches in the connectivity. We are hitting the ground running. Keep those questions, answering those questions on the chats so that we can be able to build up capacity in the team out there participating. So at this moment, we would like to invite in Richard Rugumayo to be able to give the scenario, the case presentation on which we are going to trigger our discussion for this evening. Straight away, we are going into the case discussion, case presentation. Then we can be able to trigger the discussion. You're welcome, Richard.
Thank you very much, moderator. That's good. As Ariel told you, I'm Maya Richard, and a medical officer, and Uganda's representative at International Federation of Nurse Anesthetists, the body which takes non-physician anesthetic providers in the world. Next slide. Our case scenario is on altered mental state in pediatric, and this is an 11-year-old whose initials were RR. 11-year-old boy was brought to hospital, that is Tegebo Health Center 4, by the mother at 10 a.m. 11 October 2020. So this actually it's supposed to be 2022, was rushed to emergency room and responsive. According to the mother, the boy was in a good state of health until 2 days and had slurred and confused speech, which eventually he lost. It was on this basis that the mother decided to bring the child to hospital. Upon reaching the hospital, the child was rushed into the emergency room, and immediately the primary survey started or commenced with the ABCD approach. On the airway, the patient was unable to protect the airway and could easily lose it due to the tongue constrictions. So the team had to manage this baby by positioning with the maneuvers, that is head tilt, chin lift, and jaw thrust. Then suction was done. So immediately after noticing that the baby couldn't maintain the airway, an anesthetist was called who came in and intubated with ETT size 5 internal diameter and was secured at 14 centimeters, non-cuff. Then breathing, for the breathing, the boy had noisy breathing with slow breath and SpO2 90% at room air. Management, administration of oxygen 100% by bar ETT ventilation from a concentrator, and the SpO2 after that increased to 97%. Saturation, the capillary fill was less than 3 seconds. Blood pressure 90/70 millimeters of mercury, pulse 70 beats per minute. The team established an IV line whereby a large bore cannula was used, that is gauge 20, and administered 500 mils of normal saline. The pulse improved slightly to 90 beats per minute. Disability, the patient was unconscious, Glasgow scale of 5, and AVPU was at U. Temperature 38.8 degrees Celsius. Blood glucose and malaria were checked, and the RBS was 3 millimoles and malaria positive. PPU, the right one was small and the left dilated, and all of them were non-reactive to light. Motor and sensory exam was unable to be performed, and the clinician noticed twitching of the left side of the head and the left arm. So the management was, the team gave dextrose cotton news. Diazepam and anti-malaria artesunate was prescribed, though they were out of stock. The nurse was around, had to do this pointing, rectal paracetamol, 250 milligrams was given. At that time, the team agreed to consider referral to the Port Regional Referral, whereby the coordinator, that is Dr. Patricia, was informed, who tried to look for an ambulance because the district has no functional ambulance. Exposure, the patient was examined from head to toe. A slight cut was found on the right side of the head, superior to the ear. No marks on the chest, and the chest movement was equal. The genitourinary, the boy had urinated in the trousers. So management, the team, shaved the right side of the head, irrigated the small wound, the small cut wound, which was approximately 2 centimeters in width and a half a centimeter depth. It was not actively bleeding, and the wound was dressed. Immediately after that, we went on to the sample history, whereby the mother said that the baby had two days frontal headache, dizziness, 2 episodes of vomiting, and jerking movements of the left face and the arm. The mother again reported that the boy was confused first, then eventually, before coming to hospital, lost the speech. No history of allergies, no history of any medication. The boy had malaria 2 weeks ago, which was treated and improved. The child has had 2 episodes of vomiting. There were no events registered. So the team came out with a problem list, whereby 1 is the pediatric patient, 2, the pediatric patient had altered mental status, the pediatric patient had a compromised airway because of the altered mental status and the level of consciousness, and of which who could easily lose the breathing and the airway. The team also noticed abnormal movements of muscles of the face and the left arm, low blood sugars, fibroid illness. By that time, the temperature 38.8 degrees Celsius, and the MRBT was positive. On exposure, the clinician found a small cut wound on the right side of the head. So plus or minus trauma. Secondary survey. We lost the patient after 1 hour of hospitalization, and before secondary survey could be performed, and the referral to Port Regional Referral. May the soul of the, may his soul rest in peace. Summary: an 11-year-old boy who has had altered mental status, 21 hours of hospitalization, died on attempt to refer to Port Regional Referral, managed by ABCD approach in the emergency room. Thank you very much.
Let's move into the discussion by the panel of experts. But I would like to bring it to your attention that we are talking about altered mental status and seizures. But this discussion will dwell so much on the seizures per se. We want to dive into the issue of seizures, because if we are going to analyze altered mental status, our net is going to catch little for us for the discussion. So you will see us dwelling so much on the causes of seizures. And indeed, the case that has been presented to us offers an opportunity for the 2 panelists in the house. We have heard that this child had a febrile condition, but then there is a history of a trauma. So it gives the opportunity to our panelists to be able to discuss on the 2 ends of their expertise. So it's at this material time that I would like to And indeed, the experts are going to have an interchangeable role in discussing this our topic today. They'll be switching here and there. So there will be a bit of adjustment on our program we have made. You will see Dr. Doreen can come in, can chip in, as Dr. Professor Richard Idro will also be chipping in. So it is going to be a free interaction. It's at this time as the panelists please that the first one can give his or her short. So they are going to discuss as they please. Please, Dr. Doreen and Dr. Richard, the floor is yours to be able to open the discussion. We aim at making the science behind this topic best as we can, but make it optimal for our discussion. And indeed, participants out there, we shall keep it at that. We are going to offer the best pathophysiologies, but which we shall be able to achieve that is sufficient for our discussion. So now we go into the expert presentation of our topic.
Thank you very much. Once again, thank you for inviting us to have this discussion. And just thinking through this particular child, but also beyond the individual child, I thought maybe we could reorganize and just put it in form of the different ages and look at what can potentially cause such neurological emergencies. The neurological emergencies are often they come in forms of 3, and any one of them can potentially present with the others. One, as presented here, is the case of altered mentation or coma. The second being presentation with a seizure, and the third being a complication of that with raised intracranial pressure. So somehow these 3 tend to go together, and the same things really cause them. And so if we were to start with the neonate before we go to this 11-year-old, in the newborn area, we know one of the most common causes is asphyxia. So a baby, a difficult delivery, and a baby is born with asphyxia because of the reduced oxygen tension or the obstructed labor this baby will have experienced. The other things being infections, neonatal infections, but also in the newborn area, we have the same issues of vascular abnormalities. This may arise actually from infections. Just today, we had a case of a child with severe sepsis, or having peripheral gangrene, but also had venous strokes in the head, just because of the severe sepsis. The other very common one in that age are the metabolic abnormalities. So hypoglycemia or hyponatremia, hyperkalemia. Hyperkalemia being very common, especially in the asphyxiated babies. One thing which eventually we shall mention even later on is the neonate usually will go up to 28 days, the first 28 days of life. But the conditions which affect the child up to 2 months are similar to the first month of life. So they are treated very similarly. Now, beyond from 3 months of age, things change. The infections are much more common. And because these children have a little reserve in their body, when they present with any severe illness, they quickly use up their metabolic reserves. So they may present with metabolic derangements, hypoglycemia, like in this child, because they are vomiting, they are not eating, taking food. For the young infant, it's breast milk. For the older one, it's food. The appetite is low, they're not eating well, and even the little they eat, they vomit. And many illnesses in children also present with diarrhea. So they're having diarrhea. So the volume, intravascular volume drops very quickly. So they are often hypovolemic. So like in this child, they respond poorly. And so you have the infections and then the acute metabolic derangements, and the metabolic, including hypoglycemia especially, but then also disorders of sodium. Very young infants, if I went back to the neonate, who takes a cow's milk, they have a bit of diarrhea. Cow's milk has very high content of salts, calcium and sodium. So they may develop hypernatremic dehydration. Then in the other area is we are the third leading country with sickle cell anemia. So beyond infections and acute metabolic derangements, we have very many children who present with sickle cell problems, strokes. So these ones are relatively common, and this age group, and it depends partly where you are in this country. The highest concentration being in Acholi and Lango, and then coming in the east, and then going on the other end of the west, the extreme west around Kasese and Rwenzori area. So stroke in that age group is much more common. And then, of course, is the challenge of traumatic brain injuries. We have the borders everywhere. This child had a cut on the head. So the question is whether this was related to the traumatic brain injury. Is it a combination of the two? Although given that the child had a fever, had been unwell before lapsing into unresponsiveness, my feeling is that most likely this child will have, it may be the malaria, and the child might have had a seizure, and then in the process fell and injured the head, and the deep coma being due to the hypoglycemia. And having, in children with cerebral malaria, having coma, having anemia, and having hypoglycemia, those three, you can lose up to 50% of those children, and very rapidly in the first 4 hours of presentation in the unit. So speed is important. The other things are not very, they are less common, but these ones are really much more common. Inborn errors of metabolism, some brain malformation, the things in children who have epilepsy. If the child was brought by a person who was found on the way, we did not know whether this is a child with epilepsy or not, that will have been an instance. But the much more common ones are the infections, the acute metabolic derangements, the vascular problems with stroke, traumatic brain injury, and then in the newborn, asphyxia and problems of prematurity, including bleeds.
Okay, thank you so much. We've heard from the insights of the pediatrician, and he has really given us a handful of the causes. Before I shift the microphone to Dr. Doreen, I like the way Dr. Idro has really pulled everything for us. And indeed, the list of causes for altered mental status and seizures in pediatric ages seems to be a handful of them. The list seems to be a long one. But before I call in Dr. Doreen, I think Dr. Idro brought it out clearly that apart from the common three we know in adults that causes the altered mental status and seizures, we are talking about hypoglycemia, we are talking about electrolyte imbalance, we are talking about dehydration. But I think you really brought it out that even other chronic conditions are brought on board as part of our differentials for the cause of altered mental status and seizures. From the insights of Dr. Doreen, you've seen the scenario, and indeed I was on the sideline discussing with Dr. Idro, asking What a coincidence that this child could have had malaria, and then at the same time, trauma comes in, and we end up losing him. So it's at this juncture, Dr. Doreen, that you come in and give us the viewpoint from the emergency medical physician. Thank you so much.
Thank you, Dr. Idru, for setting the pace. Just to take us through a few operational definitions.
The host, we seem to be having some problem with the audio. Can somebody help us to understand what's going on?
Okay, sorry about the audio. Just to recap, I was starting off by defining what altered mental status is. This is just a general term that refers to the change of an individual's average mental state from the baseline. Baseline basically means what has this person's average mental state been like? If there's been a change, then you have an altered mental state. In adults, you can kind of divide it into four. You could have delirium, you can have dementia, you have psychosis, and you have coma. Delirium results in confusion, lack of awareness. It occurs more acutely. I could refer to the scenario in case when someone drinks alcohol or they've taken recreational drugs, there's that acute state of confusion. Dementia presents more gradually, more progressively. It's associated with loss of memory. Someone loses the ability to make decisions, critical thinking, very common in degenerative diseases like Alzheimer's. Psychosis is usually characterized with hallucinations, delusions, and coma usually is just an unarousable state. So someone is not responsive. So based on that brief operational definition, you can get an idea that altered mental status encompasses a lot of things. Seizures basically means that there's an abnormal electrical activity going on in someone's brain. By the time there's something abnormal going on in your brain, it means that your mental state is affected. So the seizures can be a presentation of altered mental state. Okay. So I'm trying to tie up the two together. Okay. In adults, the causes of altered mental status are very similar to those in children. You can categorize them based on the etiology. If they're vascular in nature, they're very common presentations are cardiovascular accidents. So if you have a thrombus or you have a bleed due to high blood pressure or to diabetes. The other thing could be that probably it's traumatic, which is very common in our setting. So you could have a closed head injury or an open head injury. You could also have symptoms that are brought about due to metabolic issues, like Dr. Idru had said. Most commonly, we are dealing with hypoglycemia, but also in adults, hyponatremia, hypernatremia, hypercalcemia. Also, the magnesium can cause altered mental status. You could also have endocrine issues. So if you have a problem with the thyroid leading to thyroid storm, if you have a problem with the adrenal glands leading to adrenal insufficiency, In this area where we have substance abuse, you could have an alcohol-related coma, you could have a drug overdose, even within facilities in case someone is given an overdose of paracetamol or opioids, or even poisoning. We have organophosphate poisoning, okay? The other issue is that it could be neoplastic in nature. So you could have a tumor-related condition, but also let's not forget about the autoimmune causes. In adults, you could have autoimmune epilepsy, autoimmune neuritis, and so on and so forth. So as you can see, the causes really spread across so many areas, depending on the cause and depending on how the person presents. So as you approach a patient with altered mental status, I think beyond what is in front of you, you could be dealing with an infectious cause. In our area of cerebral malaria, you could also be having syphilis, you could be having TB, you could be having HIV. And like this case, this boy probably had malaria. So there are a couple of things you have to think about. Think about the etiology, think about this person's social lifestyle. Are they occasional alcohol drinkers? Do they use drugs of recreation? Think about their livelihood. Are these farmers? Could they be exposed to organophosphates? Think about this person's way of life. Could this person have been exposed to some sort of traumatic injury? Think about their past medical history. Could they have had a drug overdose? So always go beyond when it comes to the causes of altered mental status.
Okay, we'll put Dr. Doreen. And before we started, we had 3 major objectives to cover. And I would like to say thank you so much, our experts, because you have been able to deliver on the causes of altered mental status. I hope participants out there, you are already enchanted into and you're diving into our discussion by the case presentation and now the insights from our experts. The other objective we are supposed to perform on is us conducting an assessment and investigation of a patient with the altered mental state and seizures. And I think still this is going to be fluid. Our experts shall be able to ably interact and be able to deliver on this in their free will of interaction. And I think due to the technical issues, we have had lots of time. We are already into the time to discuss the assessment and investigation of patients with the altered mental status and seizures. And still the floor is for the experts to take on.
Okay. So the goal of your initial assessment is you want to identify the living conditions, and those that you can reverse them as fast as possible. You want to avoid complications associated with altered mental status and seizures. The quickest way to do this is to do your ABCDE. I love the ABCDE because it allows you to do simple things, but do them excellently and have, in a systematic way and have outstanding response for your patient. So how do you do your ABCDE? I think we are very well versed with the ABCDE, but just in line with altered mental status, what are you looking out for? The very first thing you want to do is make sure that you assess the airway. Like this boy who came in, you want to assess and make sure that you have an open airway. You want to assess and make sure that if the person is vomiting, you want to avoid aspiration. If you need to use any adjunct like your oropharyngeal airway, use the oropharyngeal in case you need to suction, you should suction. In this case, this boy was intubated, so most likely all those adjuncts had been used. But the important thing is before you rush to the seizing patient right in front of you, remember that the airway, if it's compromised, most likely this patient will die very fast. The other thing you want to focus on is the breathing. Remember, when someone is seizing, you're disrupting blood flow to the brain. When you disrupt blood flow to the brain, it means the brain is not receiving oxygen and the brain is not receiving glucose, okay? So you want to, most likely at this point, your breathing could be affected. So you want to go through your systematic breathing. You want to check and see the respiratory rate. You want to check and see if there's any chest rise, because your hypoxia can also make the situation worse. So put on your oxygen if you need to, bag your patient if you need to, support their breathing as much as possible. Remember that there are certain conditions like DKA, which can present with slow breathing. It also causes altered mental status. In your Cushing's triad with increased ICP, it also gives you irregular breathing, and this also presents with altered mental status. In your circulation, remember lack of perfusion will just make things worse for your patient. So it's very important that you support your patient, ensure that there's circulation going on. So go back to basics, check the pulse, check the extremities that they called, check your blood pressure, if the person is bleeding, arrest any bleeding. And remember, if your patient is in shock, shock can also give you altered mental status. Remember, in shock, there is no perfusion. So there's not enough oxygen going to the vital organs. In this case, this boy had circulatory compromise. His blood pressure was low, his pulse was low. The team attempted to give more fluids, which was necessary. So it was actually very good that they went through the circulation. You move on to the disability. In disability, you want to assess the mental state of this person. Check your AVPU or your GCS. I'm sure we're all covered that with these two and what they mean. So in children, it might be a bit difficult to do a GCS, but a quick AVPU will give you a guide. We know that if someone is alert, it probably responds to a GCS of 15/15. If someone is at B, it responds to a GCS of 13/15. If you're at P, you respond to a GCS of 9/12. And if you're at U, probably you're unresponsive between 3/8. All those have implications. I mean, if you're sitting on a patient whose GCS is 8 in your ED, this patient needs critical care. So, and of course it will guide you because you'll be able to know what's this patient's baseline. They came in at a GCS of 13, okay? If the GCS continues to deteriorate, it can help you to monitor your patient. So if today the GCS is 13 and tomorrow it's 11, the following day it's 8, this patient is deteriorating, okay? And like I said, a seizure is an abnormal electrical activity. Someone could be seizing, but there might not be any manifestation on the body. So they might be having an absent seizure, and also because of probably the medication you're giving them, they could be sedated. You might not actually see a seizure. And I'm sure Dr. Idre will talk about in children, presentation of seizures are not as adults, you know. So a child like this child will just come in with flickering, someone might just be staring at you blankly, they might be mumbling and fumbling, and that could actually be a seizure going on. So you have to look out for those key things. So back to disability, your blood sugar, I'll keep saying about blood sugar. Hypoglycemia is very common in our setting, especially for children because of their feeding and their age, but also in adults, especially in alcohol intoxication. Hypoglycemia will definitely kill your patient very fast. So check your blood sugar, know what the baseline is. If you need to intervene and give your D50, give your D50. In children, we give D25 and D10. Then check the pupils. Your pupils are going to be a guide. The pupils are like a window to the brain. So if you have poisoning, your pupils will show you. If you have drug overdose, your pupils will show you. If you have a space occupying lesion, your pupils will show you, okay? So all this can guide you to what exactly is causing the altered mental status in the patient. In your disability, since you're dealing with AMS and seizures, you could go a step further and assess for muscle tone and power. You could go ahead to check and see if there is any muscle weakness. Muscle weakness could point you towards electrolyte imbalance. If there is one side that is weak, then the other it could point you towards a vascular abnormality, so a stroke. So basically, as you're going through ABCDE, if you go back to the causes that we outlined, you're actually trying to identify what is causing the altered mental state in this person. As you go to exposure, you're going to look out for any other causes of altered mental status. Check for any traumatic issues. This boy had a cut on his face. So he could have fallen down, or he could have had a seizure and had a fall, or any other issue really. So it could point you towards the etiology, and then also look in our setting where we have a lot of substance abuse, look for needle pricks. This could indicate recreational drugs, people taking heroin, people taking pethidine, and so on and so forth. As you expose, the temperature should also be taken, so this could guide you to a febrile issue. And so as you go through your ABCDE, this is a continuous assessment. Keep reassessing. Whenever you do an intervention, go back and assess and see, has my intervention helped? As you go through your ABCDE, right now your thought process should be what is causing the altered mental status in the patient, and that will guide you to the management. So the initial approach is do your ABCDE. When you're completing ABCDE, you already have a differential in mind. But the beauty about it is that by the time you have a differential, you've already identified life-threatening conditions like respiratory distress, hypoglycemia, or probably you've identified a circulatory issue and you've managed it. After your primary survey, you're going to go and take a sample history like the guys did in Chegegwa. The sample history again should be focused. In your signs and symptoms, you're looking for something that could point you towards altered mental state, like any history of fever, headache, overfall, any abnormal movements, you know. In your A, any allergies, any drug allergies. In your M, you're looking at past medical history. Is this an epileptic? Is this an HIV patient? Is this a patient who has Alzheimer's? Is this a patient who has high blood pressure or diabetes? In your past drugs, you want to know what drugs are they taking. Your last meal, you want to find out when did they last eat. In children, of course, you want to find out, because that will probably put them at hypoglycemia, but also in adults. And then E, you want to find out events surrounding this illness to kind of tie up things together. The last approach will be a secondary survey. Secondary survey is very detailed. I would suggest at this point you can go ahead and do a full neurological examination. A full neurological examination has different components. You want to do a mini mental state exam. You want to find out the mood of the patient. You want to find out their affect. You want to find out their appearance, you know. You want to probably do a motor exam, check the tone, the power, the reflexes. You want to do a sensory exam. You want to also examine brainstem reflexes. You probably want to assess the gaits, you know. So, but you should not focus to do a full neurological exam in your primary survey. You could push it to the secondary survey. So that by the time you're done, you have an idea. And I like the way the team in Chegegwa had a problem list. You have a full problem list identifying where the issue is, and then you have a differential list, a differential diagnosis to guide you. Is this an infectious issue? Is this a metabolic issue? Is this a traumatic issue? So based on your problem list, it can then guide you into the management. Thank you.
Thank you so much, Dr. Doreen. You really delivered to the task. And I would like to take it from you that, yes, I work in a setting where we definitely follow the guidelines of emergency triage and treatment therapy. And this ABCD approach makes it very simple for us. It's bedside. You may not need to move the patient. So you have an opportunity to do an assessment bedside. Before now, you list the investigation the patient is going to go for. Then I also know that the ABCD approach prioritizes which system is more at danger to be rescued before the system shuts up and then the entire patient becomes a casualty. So it is very easy for us who deal with the adults But then it's at this point that we would like to invite in Dr. Idro, because these children are not young adults. So we want to hear from you, what will be the approach in our evaluation of this pediatric patient? You're welcome.
Thank you very much, moderator. Doreen, thank you very much for an extensive description. The approach is the same. And really what you have done in detail is to describe what you have described in detail is exactly what we do in the child. And especially for the smaller children, but even also for the bigger one. The idea is to just go after the initial emergency assessment that you have checked the airway, because before you do any other things, performing all your assessments is going to be useless if a person's airway is obstructed, if that person is not breathing, because that's where you're just going to start. So those initial things. And after you have had those initial things that you have checked that the airway is open, the person is breathing, and we remember we are dealing with 3 interrelated neurological emergencies: coma, which may result from a seizure, or the noxious agent causing the coma, producing both coma and a seizure, and because of the injury, the brain may swell, and then you have raising the cranial pressure. Really 3 things all presenting together. So somehow, as you assess one, you also deal with the other one. So right from the onset, and especially if the person comes to you seething, or with an unaltered consciousness, if the person is brought in the emergency unit, the assumption is that this person has had a seizure longer than 5 minutes. So that your response is you take and treat this person as a person who has status epilepticus, so that you escalate it straight to that level. But in looking at it, often what I found useful and what many people do is to just look from the head to go down to the toe. So the vitals you have stabilized, you have put the person on oxygen, preferably as much as possible, if even going to 100% oxygen, that you have an idea of the level of consciousness. The AVPU score is very useful, it's quick, and you're able to use it there and then. And for the younger children, if you have to go into more detail during either the sample survey or during the extended survey, you can give we use the modified Glasgow Coma score, because some of the children may not, they don't talk, they use a different kind of speech, or even the Blantyre Coma score. The Blantyre Coma score is very simple, it gives a score up to 5, but the AVPU score is okay, and you can just use that until when things are all stable. Then you observe the other things, injuries like in this child. So because you may have an indication it's a traumatic brain injury, that you, 2 is using your sense of smell, especially in toddlers. They put so many things in their mouth, children 1 to 3 years. For example, in our coffee producing areas, people are putting some of the chemicals or even paraffin in. Unfortunately, it's put in soda bottles, and the children like soda. Anything in a soda bottle, they are going to drink. So paraffin poisoning or organophosphate poisoning. The paraffin, you can smell it. The organophosphates, many times you can smell it. But when beyond the smell, when you start looking at the face, some of the changes you can see. So a child who is frothing, producing a lot of froth or excessive secretions from the mouth, it may be a seizure, or it may be related to some of these toxins. But the other one are the pupils. In many of the poisons, for example, the organophosphates poisoning, the pupils tend to be constricted, So as you survey coming downwards, looking at the size of the pupil, it can give you an indication. But where they are dilated, there is the potential risk that this patient may have a raised intracranial pressure. For the younger children, especially 18 months or under, the anterior fontanelle has not yet closed. It tends to close usually at around 18 months. The posterior one closes much earlier. So feeling the anterior fontanelle is important. Where it is bulging, it may suggest that there is from raised intracranial pressure and often it's meningitis, or if there is an intraventricular bleed or something, a bleed which has occurred inside. And quickly it starts pointing you to a possible diagnosis. Looking at the face, facial symmetry, if the face is turning to one side, there may be a possibility that there's a facial nerve palsy, which may mean that the person has experienced a stroke. And this is important, especially like children who have sickle cell anemia or those who have had problems. And then motor. If the child is deeply unconscious and there is, say, a stroke, sometimes it's difficult to recognize, but the postures which the child takes, usually the muscles which hold the legs, the adductors which hold the leg are quite strong. So much so that if you see they are weak and the leg turns outside, it suggests that there is a weakness on that side. And if the arm is, one arm is extended and the other one is in a flex position, it tells you that most likely there is a stroke, there is weakness in the contralateral brain. And because, especially in children, some of the seizures are not so overt. You have subtle seizures, and many of the subtle seizures you can see with abnormal eye movements, even nystagmus or rotatory movements, and there may be some drooling, and you may have, and especially in the younger infants, because melination of the brain is not all, you may have focal jerk in the fingers on one side, and then another one also in the leg on the opposite side because of the multifocal. So a careful observation, you must see twitching on the lips that the seizures are ongoing. And then with circulation, I had already mentioned that their results are very small, so the changes are quite rapid. When as you do your capillary fill time, the peripheries, many of them may have temperature gradient, and it tells you that the perfusion is reduced. And in the newborn, you can actually see a dusky discoloration of the peripheries, and it tells you that the circulation in this child is impaired. But all through this and with many things which Doreen had already described, you are able to come up with, is this probably due to an infection? Is it trauma? Is it a vascular problem? Is it poisoning? And quickly, so that you can then attend to what the possible causes can be.
Thank you so much. And we have been enchanted. And yes, I guess members online, you're already in. You have been brought in to the discussion already. All that said, I think we are able to move on now again. I is suggesting that we should be in the session of discussing the management of these patients from across the divide. The adult emergency patient with seizures, with altered mental status, and then the pediatric patient. So, and I think I'll take it, Dr. Doreen. You had already hinted in discussion of assessment and investigation. You talked of determining the ICU care in there within the primary and secondary surveys. So I think that straight away takes us into how do we now approach the management of this emergency patient?
So before we dive deep into the management, most times what will happen is we've had scenarios where someone is brought you into the ED and attendants are telling you they've had a convulsion. Most times they won't say convulsion, so okay. So your role as a practitioner, first of all, you want to really confirm, was this really a seizure? Most times you're going to get collateral history from the attendants. So you have to find a way of actually confirming that a seizure took place. It's easier if someone has seized and you've witnessed a seizure. It might be a bit tricky if someone is brought to you with a history of this person was convulsing. So once you actually confirm that a seizure has taken place, from your history, you ask about, bowel movements, you ask about eye movements, you ask about tongue biting, you kind of tease out the things that could point you towards an actual seizure in this person. Once you've confirmed that a seizure has taken place from your collateral history, and if you're lucky enough and you actually witness your seizure, you go through your ABCDE approach. As you go through your ABCD approach, you're going to start managing, again, identifying and threatening conditions and managing them. It's very important. There are key things you should never forget. For a patient who has altered mental status, always protect the cervical spine. Always assume that it's traumatic and unless ruled out. So protect your cervical spine, make sure that the airway is open. You want to ensure that this person is getting sufficient oxygen. You want to ensure that monitoring is done. So put on your pulse oximeter, put on your cardiac monitoring. You want to check the pulse, the blood pressure. You want to check the temperature of this person, because all those are going to point you towards the initial cause of altered mental status. It's very important that if this person is in need of fluids, you can give fluids. Now, it's as you approach this patient, I think the key is individualize your patient. So this basically means that there's an umbrella under which you manage your patient, but individualize the management based on what the patient presents with. If a patient presents with circulatory compromise, basically that means if the patient presents to you and they're in shock, give fluids, okay? Not every patient that comes in will need fluids, yeah? If a patient comes to you and probably their blood sugar is 2 or 3 millimoles, you give your D50. This doesn't necessarily mean that every patient who comes in seizing should be given D50. So you have to approach the patient based on an individual basis, and your ABCDE helps you identify that. But specific to seizures, what you want to do is give anti-seizure medication. First line treatment are your benzodiazepines. Very commonly, we all have diazepam in our ED. Diazepam can be given IV, in children it can be given rectal. But also when we have psychiatric patients who present to us, they're agitated, they are violent, we could try verbal de-escalation, you can still give IM, diazepam. Yes. But specific to seizures, your first line treatment is your benzodiazepines, you give IV diazepam, 10 milligrams, Dr. Idro will go into the dose for children. And you could give this to us it has a ceiling dose, which basically means that there's a maximum level we should reach with diazepam, which usually in our case for an adult is, you give it to a maximum of 3 times in 24 hours, which means a total of 30, 3 times, sorry, of IV diazepam. So once you're given your diazepam and realize that this person is actually still seizing, most likely you're now dealing with someone who has status epilepticus. But also, you're not dealing with the actual cause of the seizure. So by the time you've given your first dose of IV diazepam, it is at this point that you're trying to pull out what is causing this person to seize. Is it something that's infectious? So is it malaria? Is it syphilis? Is it TB? Do I need to give my anti-malaria medications? Is it probably traumatic? Is it a TBI? Is it something probably that is metabolic? Am I dealing with hyponatremia, especially in the adults, in the elderly, sorry? Or is it something that is endocrine? Am I dealing with a thyroid issue, an adrenal issue? So I think, do not, I'm going to say this in quotes, as an ED practitioner or as a first-line health practitioner for your patient, by the time you're going to your third dose of IV diazepam in 24 hours, you should have an idea about where the cause is, and you should be giving it alongside with specific medication for the cause. That's why your ABCD is important. If it's if it's opioid poisoning, you give the naloxone. If it's organophosphate, give your atropine. If it's paracetamol, you give your N-acetylcysteine. If it's other poison, you go through a toxic screen. So I think the key home for the management of these patients who come into the ED, go through your ABCDE, identify the life-threatening conditions and manage, identify the specific cause of the seizures and manage it specifically, okay? Also have an individualized approach towards your patient. That means that do not benchmark under umbrella and say for all patients give fluids, for all patients give D50, for all patients give naloxone, for all patients, no. Individualize your patients, identify which kind of patient is going to benefit from my fluids, how much fluids am I giving, which kind of patient is going to benefit from D50, how much D50 am I giving, which patient is going to benefit from antimalarials, how much am I giving, and so on and so forth. Of course, by the time you have done this, you have to investigate. You need to do bedside investigations. So your blood glucose, your baseline investigation, CBC, your LFTs, your RFTs, your electrolytes. Then probably you want to do your brain CT scan. But then again, this is also individualized. This means not every patient should have a brain CT scan. No. This means that not every patient should have RFTs taken. You should have a justification for why you're doing RFTs. You should have a justification why you want to do thyroid function tests. You should have a justification as to why you want to do a brain CT scan. If someone comes in and it's an index seizure, the first time you've had a seizure in a 35-year-old, no other coexistent diseases, there's no history of substance abuse, you wouldn't really rush to probably do a brain CT scan in such a person. You know, you probably want to observe and assess. So again, your investigations should be individualized. They should be patient specific, but also I want to encourage the team that as you are managing these patients, let's practice patient-centered care. That means that involve the patient's family as much as possible in the care of this patient. Respect their wishes, respect their concerns, respect their decisions, but also as a practitioner, your role is to educate them so that they can make an informed decision as you manage this kind of patient.
Okay, thank you so much, Dr. Doreen. And I would like to share with Dr. Idro that those things Dr. Doreen is talking about, I come from the practice she talks about. So, and indeed, Dr. Doreen, we look at the outcome for our patients should be in reducing the turnaround time in making decision for this patient. And these investigations need to be made as precise and as specific as possible to reduce on the time of waiting and delayed decision for the patient. But then I guess even members out there online can be able to be eagerly waiting for your input to see how we approach the management of a pediatric patient. In our 10 minutes left for handling this objective.
Thank you very much. When you look at the epidemiology of these problems, they are more common at the extremes of life. So they are much more common in the child, and the burden reduces there is a small peak during adolescence. Sometimes they engage in risky behaviors. It drops a bit, and then it starts increasing in late adulthood, going into the elder, where the risk increases. And these are serious conditions. They kill, people die. Coma, admitting a person with coma, as we saw in this child, the persons can die. Those who come with status epilepticus, you can lose up to 10% of them. So it's really serious business for us as health workers, that things are done systematically as Doreen has described, but done quickly, and that we are prepared, that when they reach, we have the mechanisms to put in place. Having said that, I wanted to mention something back in the physiology of these things, because they underlie some of the treatments which Doreen has just described. Why do we do those things which we give? All our bodies have the homeostatic mechanisms. If some particular elements drop in us, the body is such that it quickly starts correcting. So the brain cells, they depend a lot on oxygen and the supply of glucose. And within a very narrow acid-base status or pH. As soon as this drop, the body sets in mechanisms to try to correct. A brain cell which is firing, because that is what happens in a seizure, that you have either focally in an area in the brain or all over the brain, you have groups of neurons which are firing excessively. They require very large amounts of oxygen and glucose to be able to maintain that. And for the body to do that, the body quickly recognizes the need, releases adrenaline, and mobilizes glucose. Your respiratory rate increases when you're having the seizure, so that you're able to supply adequate oxygen. Your heart rate increases, and the stroke volume, the heart beating also increases, so that the cardiac output goes up. The body goes to the liver and starts releasing glucose from your liver store, also from the muscles, so that in the first few minutes, if you did a blood sugar on that person, actually the blood sugar will be high. And it will be deceptively high because the body is quickly mobilizing, compensatory mechanisms. But these things can only last as long. And in a child who has been unwell for a few days, has not been eating very well, it can last for a few minutes. And so much so that in the patients, usually seizures when they start, they usually last 1 to 3 minutes. And the body has compensatory mechanisms to stop them. And seizures which last that long, 1 to 3 minutes, usually the brain, you do not get a brain injury from them, because the compensatory mechanisms quickly take over, they supply enough oxygen, enough glucose, you don't sustain injury. The problem is when things start going 5 minutes or longer. Then you'll have exhausted your stores, and then you have injury. And because of that, if a person starts a seizure in a hospital, that you are quickly taken note of when this thing started, you have called for help, you are protecting yourself, you put this person in a safe place, and the adults, it's a lot more difficult for us children. You have to carry quickly, and you put on the sides, you get an oropharyngeal airway, you put this child on oxygen, and many times it stops. But when it has not stopped, beyond 3 minutes, we start preparing to stop this seizure activity. For us, we do not use the 50% dextrose, we dilute it, we make it 10%, and then we give 5 mils of that per kilo. That is our target, so that it is not so concentrated in it's not so viscous as you inject it. So we use 10%. That's one difference from them, from the adults. Secondly, as indicated, we give the diazepam. If you do not have an IV line, we give at 0.5 milligrams for each kilogram, and that is rectally. So you draw it for each kilo. Many children about 1 year are about 10 kilos. So that will go about 5 milligrams there. You give it rectally. But if you have an IV line, then it's 0.3 milligrams for each kilo. We do not give diazepam intramuscularly. It is oily, and remember, these children will have compromised volume, so it will stay in the muscle. It is not absorbed as well. It will stay in the muscle, and you'll not be treating what you're supposed to treat. So at 5 minutes, we'll give this first dose of diazepam, and then we go to the surveys. And our hope is that this will have stopped. But if by 10 minutes it has not stopped, then we give the second dose. But by that time, we expect that you should have obtained an intravenous line. So the second one, 10 minutes after the first one, should be given intravenously. And if the child is collapsed, in many of our settings, we have been training people how to give intraosseous treatments, especially in the toddlers. Then you can give it intraosseous, so that you are able also to give your glucose there, you're able to give your fluids in intraosseous. So the second dose, which you are giving 10 minutes after the first one, should be somehow parenteral, either IV or intraosseous. And we then observe this within another 10 minutes, it should have stopped. If it has not stopped, that's at 20 minutes, we load with intravenous phenobarbital. And one of the reasons is, as it says, there is a ceiling for the benzodiazepine dose. Benzodiazepines are respiratory depressant drugs. And in children, we do not want to go to beyond 1 milligram for each kilo in 24 hours. So if you gave 0.5 milligrams rectally, and you repeat it, 0.5 milligrams rectally, and with the regular absorption, and eventually they all get absorbed, you have already reached 1 milligram per kilo. That is a ceiling. And having that in a child who is already with compromised level of alertness, a child who may be acidotic, a child who may have raised intracranial pressure, and a child who is hypovolemic, you may compromise this child's breathing very quickly. So the next one we said should be IV, and then you now don't go to diazepams, we go to phenobarbital. And if that starts failing, you better call for help. Beyond that, you really look for help. And because the phenobarb, we give 15 milligrams per kilo, and we could give it slowly over 20 minutes. So it means you sit there, the child is on 100% oxygen, you're pushing your phenobarb very slowly. We are not loading, we're just not pushing it in, but a slow push over 20 minutes. And by that time, literally, you're going beyond 40 minutes, 45 minutes. And if it does not stop, things are not good. This child needs response. Now, the situation is a bit different in the young infant. The neonate and the first, in the second month of life. From 3 months of life, we do exactly this. But for these young ones, in the brain, we have the inhibitory neurons. They tend to stop the seizures. They want to stop it. And that is what diazepam and what phenobarb target. But in the newborn, that mechanism, particularly the one for diazepam, the benzodiazepines, diazepam, lorazepam, midazolam, may not be well developed. And instead of stopping, because they're pretty immature, they may actually accentuate. And because of that, we don't give diazepam for neonates. So if you have a neonate who comes with a seizure, please start straight with phenobarbital. And this time we load with 20 milligrams for each kilo. We don't give the diazepam, and then you can, if you are in a health center 2, health center 3, and you can refer to the next one, health center 4, or the general hospital, but you will have given the phenobarb. Do not give the diazepam. So those are some of the differences in the approach in the pediatric patient. Yes.
Thank you so much, our expert. Dr. Idro, you've ably delivered on the task of taking us through the management of this emergency patient who is a pediatric patient. And for the participants out there, I like the beauty of how it brings in the small details on how we have to be adjusting the doses. And I think we may be in the panic mood, make wrong decisions of treatment. But I think this, for the sake of this child, this pediatric patient, those words he has been able to put across, we need to pay attention to them. The dosing differences for adults and the children. We have moved on, and time is not our best ally. But then before I open the questions, I bring in the questions, I would like to go back to Dr. Doreen. In our care, in our management, we were able to talk about, we're supposed to talk about the disposition of this patient. Maybe as we open the questions on the chat aids, we would like to hear from you. How do we do the disposition for the best outcome of this patient?
So where should this patient go? You should be able to make the decision about when this patient leaves the ED. So at what point in time, where they are going, and how they are going to where they're supposed to be. So if you have a patient who is still unwell, who is still having convulsions, whose circulation is still compromised, who is still altered, and you've kept this person in your ED for more than 8 hours, you definitely need to ask for help. So from the first time you have a patient who comes in, they have a convulsion, their GCS is low, probably their vitals are off, the blood pressure is low, you need to call for a bigger team. You need to start preparing the neuro team to come in and support you. You need to call in other specialists to come and support you. And by the time you're having a second convulsion, most likely you're thinking to yourself, I have not identified the cause of the convulsion, or I need specialized care. So I need to get critical care to this patient. So you need to start thinking about where is the patient going to go to? Is there critical care being offered at your facility? How am I going to take this patient? By the time they're having the third convulsion still in your care, now most likely you're going into status epilepticus. Or they've had convulsions and they're not returning to baseline, most likely thinking about status epilepticus. You should not handle status epilepticus in your ED. The drugs that are given with status epilepticus are drugs that are meant to sedate the patient. This patient needs close monitoring. These drugs can have side effects. You need specialists on board to come and support you. So you need to be able to consult either a neuro team, an ICU specialist, so probably an intensivist to come in and support you. So all these are all the things you need to start thinking about. Where is the nearest facility I can refer this patient to? Then of course the question comes in, when do I discharge this patient? Who can I discharge? So again, you have to have individualized approach to your patient. There are patients who might come in, it's probably a patient who's the first time they've had a seizure. They've never had any coexistent diseases. They're not hypertensive, they're not epileptic, they're not diabetic, no history of trauma. When you do your labs, they're all normal. Nothing that could point you to something that is severe. If your patient has not had a seizure within the next repeated 24 hours, they are quite stable, you could actually discharge this patient, come for follow-up. Then of course, the question about, okay, so who then goes to the neuro ward? Who goes probably to the medical ward, you know? So again, you have to, don't work in isolation, work with a team to support you, because some of these decisions have to be discussed as a team. You might be able to consult the physician on duty or the intensivist on duty to guide you. Is this patient stable enough to move to the ward or not? If they are not stable enough, and they go to the ICU or to the HDU. So by the time you're having a patient who's coming in and they're convulsing, their GCS is low, start thinking about all these things. When do they leave the ED? Where do they go to? Who do I call for help? So those are some of the questions that will guide you about the disposition of the patient.
Okay, thank you so much, Dr. Doreen. And it's at this point still I want to involve in Dr. Idro. That yes, Dr. Idro, you talk from a point of authority in terms of decision making, you are at the top. But then for the benefit of this person attending our session out there in the upcountry units, are there opportunities for acute conditions that cause seizures and altered mental status? Are there opportunities for them to have a disposition, and then they are doing their next level action is taken, is being sent to where? Because then from you, your practice, I would be interested to know where you then do the disposition of your clients, but look at that person down at the grassroots, where they need to take timely decision, saying next level intervention should be done.
Luckily, I also worked there before coming to Mulago. So I used to work in those same units, and it's the same. It's about the structure of how you have arranged your emergency unit, and in as much as possible beyond our emergency unit, even if we have small ones, there should be an area which is for critically ill persons. And then the nurses are able to do this. You know, in that area, you have things which you can use for resuscitation, which can be used for the needs of a person who has critical illness. This is critical illness, this child. So after you have stabilized the patient from where you receive the person, assuming if it is a health center 3, it's really one place. They will have seen in OPD and just rush to most likely to the ward. If it is a slightly bigger unit, if it's a health center 4, district or general hospital, then there is a form of an ED. And then from there, you can transfer to the ward, and the ward, the area which has been gazetted or demarcated as one for critically ill children, where the nurses are able to perform more frequent observations, where there's more closer monitoring. That really, in my mind, is it. And then depending on the progress of this particular patient, and for me, I'm talking about children, this particular patient, you are then able to decide whether this particular child needs a referral or escalation to a higher level care. If a child is not improving, you have been treating this child. As he says, for example, you have 8 hours and you are there, this child is still unconscious, and you know your abilities are limited. This child needs. If this child continues seizing beyond an hour, because that is refractory status epilepticus, you know this is trouble. You need help. Yeah, you need help. Somebody you can call, but also you need to identify a mechanism how to safely move this person away. But having said that, there's one thing which I wanted to mention. I go back frequently to newborns because we have done very well in many things in Uganda. In children, our child mortality has really come down, but our neonatal mortality has not really come down. It's stagnated, and there are many mistakes with the newborn babies. One of them is when they get the infections, many times, I had already mentioned that we need to use phenobab, but also looking at etiology of the things which cause infectious agents in the newborn. It's usually not malaria. So as a health worker, we should not say that this newborn who is having this occasional seizures has malaria and we start treating malaria. Most likely it's a meningitis. Okay, it is a severe sepsis. It is a ventricular, something very serious. This newborn requires antibiotics, and the antibiotics is not for 5 days. If we rarely give newborn babies antibiotics for 5 days, it is much longer. They have many times they have infections which are from the birth canal or from the perineal area, and these are serious infections. They require between 2 weeks and sometimes even up to 3 weeks of treatment. And it is from these complications where you eventually have children presenting later on with hydrocephalus, because they do not have adequate treatments, especially antibiotics. Or somebody delayed and was fast treating for malaria because that the newborn had a fever, started treating for malaria, giving anti-malarials before starting. Yeah, and we use time. Even a few hours of lost time to this neonate is very critical. We need to address them.
Thank you so much, Dr. Idro. And I can see the chat aids are very active. We have already entered into our time for questions and answer. We lost some time due to the technical issues of the connectivity, but I think we can be able to close this in the next 15 or so minutes. Dr. Doreen, there are some questions here. I think we can be able to now attend to the question and answer session. And as well, Richard, Ugumayu's presentation, people have picked a question there. I think you can connect Richard again. So Dr. Doreen, somebody is here asking, Benjamin Ochuka, some patients with head injury may present with a normal AVPU, AVO, or GCS, which may be due to bruises on the head and other parts of the body. Then after 2-3 days, they start convulsing. What could have happened to such a patient? And is IV monitoring necessary in such cases? Dr. Doreen, that is the question I think that can be to your docket. But I would like to also bring in Dr. Idro. People have appreciated the discussion and they are all thankful of the enlightenment you have given them. One person is here asking, again, Benjamin Ochuka, they are asking, interested more on the doses of diazepam and phenobab, which you have been able done well. They are all thankful of you. And somebody says, he missed the contraindication of diazepam. This is the Oponye Dennis. He missed on the contraindication of diazepam in neonates. Is somebody here, Basiga Amos is asking, if IV phenobarbital isn't available, what other alternatives can be used in neonates? Dr. Idro, those are for you. And then somebody here called Kawijamu Ivan is asking, when do you get to know a premature is having seizures? There again. And then I think the last one for now, as you respond to them, somebody called Kiri Debo Roy has a question that in case you are planning to refer a neonate to a higher level, such that they may receive the phenobarbital, what are any referral treatment options? I think we can be able, and then again here, Dr. Idro, Peter Anabo is saying, in the case of absence of phenobarbital IV, can IV phenytoin be administered for the neonates during unprovoked seizure after doing all the assessments? I think those are all for now. I think we can be able to start with Dr. Doreen to respond to the person who asked about the use of phenobab and seizures appearing days after. against this? Thank you.
Thank you, Ronald. That question had two parts. The person was asking about why the GCS would change after head injury. So assessment has to be continuous. And when you have a patient who comes in with head injury, there are many things that happen to this patient. So you could have a patient who comes in, they are not feeding properly. So they may lead to, they become hypoglycemic. They might come in with wounds, with injuries, and you're not handling, giving antibiotics, and the wounds become infected, can lead to sepsis. This person might come in and probably they've had a small bleed in the brain that continues to expand, and therefore you have issues that are causing increased intracranial pressure. So all these things might be gradual and not really sudden. So it's very important as a patient comes in, continuous assessment is very important. So the person was asking why the GCS changes. So again, depending on how the patient comes in and based on the different factors surrounding the illness, based on your treatment and based on your monitoring, a couple of things could be going on, like I've mentioned earlier on. The use of mannitol. Why do we give mannitol? When do we give mannitol in head injury patients? So first of all, you need to assess your patient, get a baseline for your patient. What is my patient's baseline? When they came in, what was their GCS? What was their pulse? What was their blood pressure like? What was their breathing like? You need to look out for signs of increased intracranial pressure. Your pulse will help you, your BP will help you, your respiratory rate will help you, your GCS will help you. But also there are different signs. For example, if a patient is vomiting, that would be a sign of increased intracranial pressure. If your patient has a bradycardia, which means the pulse is low, which could point towards increased intracranial pressure. If your blood pressure is high, if the breathing is irregular, all those are pointing towards increased intracranial pressure. Before you rush to give mannitol, I like doing simple things. Elevate the head of the bed of your patient. Studies have shown that bed elevation actually helps to reduce intracranial pressure. Okay. By the time you're choosing to give mannitol to this patient, you're dealing with a critical patient. And mannitol has to be monitored as it's being given. You need to have a neuro assessment done for this patient. But there are things you can do to prevent increased intracranial pressure. So elevate the head of the bed, ensure that you're giving oxygen to this patient because you want to avoid hypoxia. Remember, the brain is affected. So you want to, there's something called supporting the neurocritical band. So it means you're giving enough oxygen. It means you're giving enough glucose to the brain. It means you're providing the right temperature for the brain to work. Mm-hmm. All these are things that could actually help you prevent increased intracranial pressure and also improve the outcome of your patient. So I think what we're trying, the take home for this question is, one, continuously assess your patient to avoid this sudden change in condition without you noticing it. So continuous assessment of your GCS. Like I said earlier, GCS helps you monitor. It's a monitoring tool. It gives you a baseline, and then over a period of time, you can keep on going back to assess your patient. If the GCS is dropping, you should ask yourself, why is my GCS dropping? Is it because of blood sugar? Is it because of infection? Is it because of a space-occupying lesion? All those are management of the patient. Individualized. It should be an individualized approach. Give it only when necessary and from guidance from your neuro physician or from the neuro team that's going to help you support the patient. Again, there are things that could help you to reduce increased intracranial pressure. We've talked about raising the head of the bed. We've talked about supporting the brain to work adequately. So keep your patients at the right temperature, avoid hypoxia, give oxygen, support the brain by giving the right amount of glucose, and of course, avoid potential infections that could then worsen the outcome of your patient.
Thank you so much, Dr. Doreen. And I hope, Benjamin, your question has been attended to. Dr. Idro, you are going to respond to those that we raised. We raised them in a cluster because they appear to be addressing the same issue about doses. But then as we go on with their questions, and I would like to encourage participants, please, push those questions, let them be raised and then they are answered by the experts. Dr. Idro, you will take that as I pick other questions here.
Thank you. So it's a lot of the questions had to do with the anticonvulsants. And if I may repeat, our primary anticonvulsant is a benzodiazepine. And countrywide, the most available is diazepam. The others, there is midazolam, there is lorazepam. They're all cousins, and they can be used. The doses may vary a bit, but midazolam and diazepam, the doses are the same. That if a child is having a seizure and you're going to give it rectally, you give at 0.5 milligrams for each kilo. So the assumption here is that you have weighed the child. For us, we weigh children and we give based on the weight. Please, it's really important that in such critically ill children that you have weighed the child, that you're able to give your glucose based on the weight, you're able to give your fluids based on the weight, you're able to give your diazepam or the anticonvulsants based on the weight. You must have the weight. So if in your ED, you do not have the appropriate weight scales in the next requisition, which NMS is going to deliver, can you please ask your in charge that you have a weight scale so that we're able to take the weight of these children. The first dose, if it's rectal, is 0.5 milligrams for each kilo. And we wait for 10 minutes. We hope the seizure will have stopped during that time. But if it has not stopped at 10 minutes, the next one should be either intravenous or intraosseous. And the intravenous dose is 0.3 milligrams for each kilo. But we do not want to go beyond 1 milligram for each kilo. So by the time you have given 0.5 rectally and then another 0.3, that is already 0.8. You do not want to start compounding it. Otherwise, the risk of respiratory depression. So beyond that, we go and give intravenous phenobarbital. The second thing is a lot of the questions came in the area of what if there is no phenobarbital? And these are the emergency medications. And these are the things why patients die on admission. That having no oxygen, having no glucose, having no salbutamol for us, patients with asthma, having no appropriate anticonvulsant, whether diazepam or phenobarbital. As a manager, as a person who sits in the emergency area, what do you put in your emergency tray? These are the things. And we should be able to know that what we have available is going to run out in the next few months because people die. There are times when there's no attachment in that tray, or there is no antibiotic in that tray. But these resuscitation medicines, really, in our organization, with the organization which we are having, these talks should be able to help us to plan appropriately that this is what we need. So after this meeting, we should be able to go back and ask ourselves, do we have these medicines for the next 1 month? before the next delivery comes. We should not be in a situation where we do not have these medicines because they are critical. We do not know when the patients are going to come. For me, I want to start from that angle rather than saying that if there is no phenobarb, what do I do? We know the appropriate thing to do. Let us do the appropriate thing and plan to do that appropriate thing. Yes. And then lastly, what about the manifestations of the seizure in the newborn? And this is what we have said, because the seizure they originate in the cell body of the neurons, but then the information goes along the axons, and you need the myelin covering in the newborn or in the preterm is not well developed. So they are not so organized like in an adult that you are having the whole body is jacking. You may have jacking on one arm, and then with the eye on the opposite side, or maybe the toes on the other side. So they tend to be multifocal. And many times they are so subtle that you need more critical observation. Just eye movements, abnormal respirations, just as Doreen had mentioned, abnormal heart rates. Sometimes for newborn babies, you see the child as if is holding bicycle pedals, or actually using the same with the feet, as if it is a pedaling movement. Some of them may be just hyper alert, just small things, and they jump. So the manifestations are different, they are subtle, they are multiple. But when you see them, you'll know. And these are really the things. So focal jacking, salivation, abnormal respirations, very high heart rates, varying. So it cools down, then it quickly goes up, and then you see a few of these. So when you put them together, actually you realize that it's newborn.
Thank you so much, Professor Ibro. But I think as many members in the chats asking about dosing, these doses, I think
we should dose of the phenobarb. So in the young infant, the neonate, we load with 20 milligrams for each kilo. 20 milligrams for each kilo. But from 3 months onwards for the child, outside of the young infant child, we give at 15 milligrams for each kilo because we are loading it actually in treatment of stethoscope. Okay. Yeah. And after you have loaded it, then we maintain with 3 to 5 milligrams per kilo per day. Okay. So on the subsequent days, after you have stopped the seizure on day 1 with your loading dose, every day you will then be able to give 3 to 5 milligrams per kilo. Now, how long will you continue this? If this child came, the diazepam did not work, you then loaded the phenobarb and it stopped. You can, the maintenance dose you can do for another 2 days, the day after and the day after that one for 2 days. But if this child had convulsions for more than a day, the maintenance will do at least for 5 days. But if it occurred much longer, you have to transfer even to another unit. Sometimes we maintain for up to two weeks. But otherwise, just in most of these acute managements, that maintenance dose of 3 to 5 milligrams for each kilo of phenobarb, we'll just give it for 2 days and it will be adequate.
I hope the team out there have heard. Their eyes have seen and their ears have heard the professor laboring to deliver this. But I think for us to standardize, don't we need teams out there to be able to develop this in kind of SOPs, such that we standardize how we approach this very delicate life. This is not a life for us to gamble on. And in session here, ears will have picked something and you have taken it as an individual. But what's the standard? Maybe we go on to think of strengthening the approach to this person and say, we need to have these SOPs put up, those showing the doses ranges for different age groups. I think that will work, as I see many.
I think they are there in the clinical guidelines.
We have
They are, but also in the different EDs. I mean, they should have charts on the walls that have algorithms in case of status epilepticus. This is the medication, this is the dosage, and so on and so forth. So they should be right there in the ED, that in case of anything, someone just, eyeballs at the chart and says, oh, this is the dose of phenobarb, this is the dose of phenytoin, and so on and so forth. So the team should go back and advocate for those charts to be placed in the EDs.
And I think as we are supported by the IP, SEED Global Health is activating reactive teams at sites. So maybe this is an area to streamline such that we can have a streamlined approach to these conditions. Today, taking it from the response to the altered mental status and patient with seizures, people are showing the interest of now. Maybe it was a gap, information gap, but yes, there's an excitement in asking for this information. So thank you so much. We would like to encourage participants out there, please. The post-test is launched and you are encouraged to respond to really show how the experts have impacted on you, on your learning. Please go ahead and respond to the questions. There is a question that was raised by someone, and the person is here called Wilson Aurelia Tenua. This person raised a question to the team in Chegegwa. That's where the case came from. So he said that Wilson is asking to the presenter, the vitals appear to be improving in that case of that person we lost. So he's asking, what changed? What could have changed? And I think this session is helping us to conduct like a death audit of what could have gone wrong for that patient, and using it as a learning opportunity for now doing things better next time. Dr. Doreen, I think you do.
Yeah.
On behalf of the team, take it on and respond to this question.
Well, there are a couple of things that could have gone wrong, but before we go to what went wrong, let's first applaud the team in Chegegwa for what they did. Managing a patient goes beyond an individual. You need the right team, you need the right equipment, you also need the right systems in place to support you. This child came in, first of all, right from the history, you could tell that there was a delay for this child to come in. From the history, this child had been unwell for 2 days. I think a while back had been on treatment for malaria. It wasn't documented whether the mother had gone for review or not. So there was a bit of a delay. By the time the mother came in, this child was not able to talk. So we could start right there, that the health seeking habits at community level are still very poor. A couple of things: there's accessibility to the health center, there are resources to support you to move. So we need to deal with community awareness when it comes to health seeking habits. When this child came to the facility, the team went straight into the ABCD approach. They assessed the child, interventions were done, they put on oxygen, they gave fluids, they gave anti-malarials, they also gave anti-seizure medication, they even intubated the child. So they seem to have given all the right interventions. However, by the time this child is being intubated, by the time this child had a fever, this child had a low GCS, this child was hypoglycemic, this child had a wound on the head. So a couple of things are going on right here. It's not only, it could be cerebral malaria, like Dr. Idra talked about. It could have been a traumatic brain injury. From the vitals, probably there was an element of increased intracranial pressure. So really, this child needed critical care. This child needed a bigger team. By the time you're going to intubate a child, this child needs mechanical ventilation. This child needs to be taken into ICU. This child needs an intensivist to monitor this child. this child needs an ICU nurse. So you can see that team is getting bigger and bigger. Chegegwa is a health center 4, correct me if I'm wrong. But the system issue is now moving this child from Chegegwa Health Center 4 to a regional referral hospital where they should be now an ICU, they should be a team to receive. So unfortunately, that as the case was being presented, they said there was a delay to get the ambulance. Of course, now it's a system issue. When does the ambulance come? What is it, the right type of ambulance? Is it the right team to escort the ambulance? Is the team on the other side ready to receive the child? So as you can see right from the time from home until hospital, there were so many issues, not just for the individuals who cared for the child, but from the community to the health seeking habits, from the system issues, from transportation, and so on and so forth. So it's not the kind of scenario where you're going to point and say to one thing, this is where the problem was. This is the problem that could have saved the child. No, unfortunately, that's not what happened. It starts way back from when the child was at home.
Okay, Dr. Doreen, thank you so much. But I think as I leave your side, I want you to also respond to this one. Francis Oyanga is asking, and I don't know whether you choose at your discretion to put it for us. Hello team, how do you attend to neonate with the, that would be Dr. Idro, I think, with the acute with acute mental state alteration and then seizures in relation to tetanus. I don't know whether really tetanus presents as seizures. Are those seizures? Are those spasms? I don't know. The team is asking, they are mixing the two possible.
So the tetanus is a different situation. Seizures involve the cortex of the brain. For tetanus, the toxins travel along the nerves, and where the nerves join those which come through the spinal cord at that level. So it is at the level of the spinal cord, or if it is the cranial nerves, where the cranial nerves join their nucleus. It is not a cortical brain problem. And because of that, tetanus is not generally associated with alteration in consciousness. They are conscious. But it produces spasms. These spasms are very painful. And it is in this that we use muscle relaxants. And this is the situation where now we use diazepam. Okay, diazepam here is being given as a central muscle relaxant. And again, these guidelines are available in our treatment guidelines. But we use it in combination with, so the management addresses not disturbing this child as much as possible, that the child is in a quiet place, that there is not a lot of noise, that you're able to feed this child. Of course, really we should not be getting tetanus at this age. It means that our antenatal care facilities are failed, that this mother did not get tetanus toxicity. Yes. But having, when the child then presents with it, we have to manage, of course. So it's in a very quiet place. We are maintaining adequate fluids. Remember, they are sweating excessively. The muscles are contracting. They are contracting very painfully. Any disturbance, so as little noise as possible. As little light as possible, because even in bright lights, it can stimulate the attacks. So that's why we darken the rooms. And we try not to administer this one through injections.
because more treatment.
Because you are going to trigger more of it. So if you have an empty tube in, then you're able to administer it through an empty. The other thing which we pay attention to is the autonomic involvement, the autonomic nervous involvement. If you see there is a temperature variation, and when you see that the heart rate is quite high or the respiratory rate is unstable, it means that the autonomic nervous system, which controls these things, is affected. So those particular children, we add, we give them chlorpromazine, and the diazepam is given every 6 hours, and then we alternate every 6 hours with chlorpromazine. And as soon if the respiration then becomes very unstable, then we take this child to ICU and ventilate the child until as much as possible that the tetanus toxoid loses its strength, because it goes to the spinal cord and binds on those. We give the human immunoglobulin. I think the general hospitals will be there, so please do not keep this child in the health center free. As fast as possible, transfer the child to the general hospital, where they can then get human, where they can get tetanus toxoid and give it, also the immunoglobulin and give it. You both immunize the child. You immunize with the vaccine, but we also give the immunoglobulin to try and bind the toxins which has been released, and you then take care of the wound. In the newborns, often it is from the cord. You take care of it and you give antibiotics to kill whatever live antigens there are.
Thank you so much, Dr. Idro. And to the participants out there, we cannot really exhaust this big topic in 2 hours. We can see that we are metastasizing to other now causes of tetanus, which was not part of our bite. But then we are thankful for everyone who has participated on this chat. We've seen all your questions. Time is not our best ally, but we appreciate your participation, and you made the session very active. But then I would like Dr. Doreen, as we wind up, please, participants online, we are going to have the correct answers, the multiple question answers which you are given, you are going to have the correct answers displayed. Dr. Doreen, as you give your parting shots, please, there's a question here, and I thought it required your input as we wind up. You also give your parting shots. That this person is saying, clearly Deborah is asking, in case of increased intracranial pressure, when do we consider hypertonic saline over mannitol, or I think he meant otherwise? So there's that question.
So again, by the time you have a patient and you're thinking about giving mannitol or hypertonic saline, this is a decision that should be made on guidance from a neurosurgeon or a neurophysician. Mannitol is a diuretic, so basically it works on the principle of sucking out fluid. And there are contraindications for when mannitol shouldn't be given. If you have a patient who probably has circulatory compromise, you do not give mannitol, and so on and so forth. So I do not want us to, first of all, to bear the burden of having those decisions being made by us. My answer to that question would be that by the time you're faced in such a scenario, you should have called for help. You should have a neuro team on board to support you. You should have a neuro team on board because remember, you have to monitor this patient closely. There's close monitoring involved when it comes to giving mannitol, when it comes to giving hypertonic saline. And there are contraindications for one versus the other. So my answer again to this person is consult, work as a team, call for help. Do not sit on a patient of that nature by yourself. Such a patient requires a whole team to support you. Then my parting words would be in regards to altered mental status and seizures. This is an emergent condition. Over 50 million people globally have seizure-related disorders, and 80% of them actually are in low and middle income countries like Uganda. And people with seizures and seizure-related disorders, their risk of death is tripled. And that should be an eye-opening, that if you have someone who comes in with a seizure, it means they're at risk of dying 3 times more than someone who doesn't have a seizure. It means you need to act very fast, you need to act very quickly, go back to basics, go back to your ABCDE. Your ABCDE will guide you on how to identify life-threatening conditions and to manage them. Do the basics and do them excellently, and you will improve the outcome of your patient. The other thing is call for help. Do not work in isolation, work as a team, but also consult, and referral is part of management. Know when to refer, where to refer to, and how to refer. The other parting message is be prepared. So that means when you leave this session, go back to your EDs, ensure that you have emergency trolleys with emergency drugs. We've talked about the causes of altered mental status. As you can see, they are so broad. So you need to have your diazepam on board, you need to have atropine, you need to have your naloxone, you need to have your D50, you need to have emergency antibiotics, and so on and so forth. It's a whole cascade of so many emergency drugs to help your patient improve. The other thing is advocate to have placards on your ED, on the walls, to have posters to support you as you practice. You don't want to have a child who's convulsing or an adult who's convulsing, and you're all trying to figure out what's the dose of phenobarb, or how much D50 do I give to a child, to an adult, or how much D10 or D25 do I give to a child. So you should have these things on your walls and your placards, but also back at your institutions, you should have regular CMEs. These CMEs should guide you so that you can improve your practice. So allocate people on topics to discuss so that as you practice, you're conversant with some of these things. So thank you so much for listening. Thank you to the team at Seed Global and Ministry of Health. Thank you, Dr. Idro. I've learned a lot from you, and thank you to Roland as well.
Thank you so much. The pleasure is always ours being here. Dr. Idro, and I think you are going to give your parting shots, then we shall be able to hand over to the technical team. We have run out of time. Your parting shots, sir.
Thank you very much, our moderator. Thank you for discussion. Thank you, Seed Global, for giving this platform, which improves the care of our patients, of our population. The people who fall ill are our brothers and sisters, our mothers and aunties, our children, our nephews. So by improving this, we're improving the care of our own families. And thank you for doing this, and thank you for providing us with opportunities to always learn and improve ourselves. I want to thank everyone who logged in, over 220 something, sometimes going beyond that. Thank you for joining and joining us. I see many of you are requesting for the slides. You will have noticed that we did not share a lot of slides. We thought that we will discuss these issues. You see our faces as we talk. They were just only limited slides, except the approach which was shared out. But many of these things are available in the clinical guidelines. As was mentioned, with the CMEs, and with this, we are always available. We can always discuss in the different regions, but improving ourselves, even in our small units, the audits are quite good, like looking at this child, what could have gone wrong. Going through now, we have learned quite a lot. What could have gone wrong? Why did this child die suddenly? And sometimes they do. They may either have a respiratory arrest from the raised ICP, which we're talking, or because they were so critically ill, they had a metabolic acidosis, they get arrhythmias, and they just die suddenly for us. Yeah.
So thank you so much. And me, on my part, I would like to just thank the people in here, our experts, and you people out there who have been actively involved in this session. Thank you for giving me the opportunity to be the interswitch for the discussion. And to see the global, I would like to hand over to the technical team. I would like to say that this is my singular honor and privilege, having been given this task to moderate this session up to the end. Maybe another opportunity will surface and then we can come back here. I would like to hand over to the technical team. Thank you so much.
Thank you so much. Thank you so much, our participants, for sticking with us until this time. We apologize for the technical issues that we had. We are not always like this, but technology is not, I don't want to use the word. Someone says it's not your mother, but it's, I will not use the word. So, yeah. We would like to ask you to turn on your videos and take us screenshots. It's our culture. Then also we invite you for our next session, which is going to be on Friday of the coming week, which is 9th of December. The topic and the experts will be shared. But we are so happy to always have you. Anyone with any comment as we close? We shall be happy to hear from you as you turn on your videos. I'm happy to see the faces I know and those I don't know. I'm also happy to see you. Maybe one day we shall get to meet, but for the regular participants, I can see Simon. You're always welcome. We talked about certificates. We shall give certificates at the end of the phase. And the phase is going to end in January of next year. So that's when we shall give a certificate to the regular participants. We are taking the screenshots. And thank you so much, Everyone, enjoy your weekend. Please do not drink and drive. Bye-bye.
Enjoy your weekend too.
Thank you. Thank you.
Thank you very much. Bye-bye.
Thank you. Thank you. I got you.
Okay.
Thank you, MOH, and thank you, State Global.
Much blessing. Thank you for the participation.
Thank you.